Hi everyone, welcome to renal physiology. In this lecture, I'm going to look at renal circulation and regulation. Okay. In other words, we are looking at renal blood flow. That is blood flowing to the kidneys and how that blood flow to the kidneys is regulated. Okay, how it is controlled. So first thing first, we need to know that the kidneys, they receive 25% of the cardiac output. This is cardiac output. They receive about 25% of the cardiac output, which is the highest among all the organ systems. If you remember the definition of cardiac output, this is the amount of blood pumped by each ventricle per minute. So for instance, if the cardiac output is 5 liters per minute, then 25% of that will be directed towards the kidneys. Okay. The kidney is not the only organ that receive cardiac output. Many organs of the body receive cardiac output. For example, the digestive system will receive another 25%. The kidneys, they have received 25%. The muscles, they have received 25%. So in total, 75%. There's also about 15% that goes to the brain. Okay. And there's also about 5% that goes to the skin. Okay, but here we are interested in the blood from the heart into the aorta, and then from the aorta into the renal arteries. So 25% of the cardiac output goes to the kidneys. Now, regulation of renal blood flow involves the adjustment of the diameters of the afferent and efferent arterioles. That's all. Okay. It involves adjustment of the diameters of the afferent and efferent arterioles. If you remember this equation from the cardiovascular system, blood flow is equal to cross-sectional area over velocity. Okay. There's another equation here. Blood flow is equal to change in pressure over resistance. There's another equation here. Blood flow is equal to change in pressure multiplied by these values. Okay, this is called the Poiseuille law. But let's not get confused. We are trying to say that blood flow is directly proportional to pressure. But blood flow is inversely proportional to resistance. So in terms of regulating blood flow into the kidneys, usually what changes is resistance. Okay? So when the arterioles constrict, it means the resistance increases. So when the resistance increases, it will mean blood flow will reduce. Again, when the arterioles dilates, it means it means resistance will reduce. And then when resistance reduces, it means blood flow increases. So that's why we mean when we say regulation of renal blood flow involves adjustment of the diameters of the afferent and efferent arterioles. Okay. Now there are factors that can adjust the diameters of the afferent and efferent arterioles. Okay. So those factors, we call them vasoconstrictors and vasodilators. So we'll start by looking at the vasoconstrictors. What factors constrict these arterioles? The first one is the sympathetic nerves. At the end of the nerve terminal, they secrete epinephrine and norepinephrine. This is a vasoconstrictor. What stimulates the secretion of epinephrine is decrease in the extracellular fluid volume. The decrease in extracellular fluid volume, which is very true. We know that the effect of the sympathetic innervation on the heart is that it increases the heart rate. It increases cardiac output. Okay. So the whole purpose of this is just to restore the normal blood flow or the normal pressure. So the effect it has on the glomerular filtration rate, that is the rate at which a filtrate is formed, it will reduce, and then the rate of blood flow will also reduce. Another vasoconstrictor is angiotensin II. Angiotensin II responds to drop in the extracellular fluid volume or the drop in the blood pressure. What will be the effect? The effect is decrease in glomerular filtration rate. The effect is renal blood flow will reduce. Okay. And then we have the endothelin. Endothelin, these are peptide substances or peptide vasoconstrictors released by the endothelium. You know, the endothelium is the layers of within the blood vessels. So they release a chemical substance called endothelin. So the effects of these, the factors stimulating secretion of endothelin, we have increased stretch, bradykinins, angiotensin II, epinephrine, okay, and also a reduction in the extracellular fluid volume. What effects? There will be decrease in glomerular filtration rate, there will be decrease in renal blood flow. Okay, so this is what the vasoconstrictors do. They reduce the lumen, the diameter of the blood vessels. So we expect this vasoconstriction to occur in conditions such as hemorrhage, where there is excessive bleeding. Somebody has just been involved in an accident and they have lost a lot of blood. We expect vasoconstrictors, substances to be secreted. Okay. Apart from hemorrhage, where there is a reduction in the extracellular fluid volume, for example, diarrhea, vomiting, excessive vomiting. So we expect these vasoconstrictors to be secreted. And then apart from that, there is these other vasodilators. We have the prostaglandins, PGE1, PGE2, PGE12. Okay, these are vasodilators. What can we say about prostaglandins? These are produced locally in the kidneys and they cause vasodilation of both the afferent and the efferent arterioles. So the same stimuli that activate sympathetic, okay, sympathetic nervous system and increase angiotensin II levels in, for example, in hemorrhage. It also increases. It also activates local renal prostaglandin production. Okay. So the prostaglandins, their function is to modulate the vasoconstriction produced by sympathetic nervous system and angiotensin II. Okay. Unopposed, this vasoconstriction can cause a profound reduction in renal blood flow, so resulting in renal failure. So they modulate the vasoconstriction caused by angiotensin II and sympathetic nerves. So without these prostaglandins, the vasoconstriction can become so much that it can even lead to renal failure. That's why these drugs called the the non-steroidal anti-inflammatory drugs, they inhibit synthesis of prostaglandins, and they'll interfere with the protective effect of prostaglandins on renal function following a hemorrhage. So it's very important to know that the non-steroidal anti-inflammatory drugs may have detrimental effects on the renal system. Okay, and then we have nitric oxide. Nitric oxide also, these are vasodilators. We have bradykinins, these are vasodilators. We have natriuretic peptides released by the heart. These are also vasodilators. There are others like dopamine, we haven't talked about. It's also a vasodilator. That is, in smaller quantities, dopamine will dilate blood vessels in the brain. It will dilate blood vessels in the cardiac, the splanchnic, and also it will dilate blood vessels, the arterials. Okay. So these are some of the vasoconstrictor substances that changes the diameters of the afferent and the efferent arterioles. So as we discuss the renal physiology, we'll be referring to these vasodilators and vasoconstrictors. Okay. So now, since we have understood the vasodilators and vasoconstrictors, how is the regulation of renal blood flow? Okay. So regulation of renal blood flow is mainly through autoregulation. Okay. The nerves innervating renal blood flows, the renal blood vessels, do not have any significant role in this. That's why following denervation, that is nerve supply to the kidneys, blood flow can still be regulated. Okay, that's what we call autoregulation. It is an intrinsic ability of an organ to regulate its own blood flow. Autoregulation is present in some vital organs such as the brain. It is present in the heart and the kidneys. So but however, it is highly significant and more efficient in the kidneys. Okay. So why is autoregulation important? Autoregulation is very important because it ensures that the glomerular filtration rate will be high enough to allow the kidneys to eliminate wastes and to regulate blood pressure, but not so high as to cause excessive water loss or kidney damage. That's why autoregulation is important. We know there is 1,200 mL of blood flowing to the kidneys per liter. We want to maintain this blood flow because the kidneys plays a very important role in removing toxic materials, okay, such as urea, uric acids, creatinine. These, they need to be eliminated out of the body. That's why we need constant supply of 1,200 mL per liter for it to achieve its function. Okay, so to ensure that this mechanism of autoregulation should be in place. Now this graph, it shows the range, okay? It shows the range of blood pressure that can be autoregulated. Okay. So what this diagram shows is that even if there is change in blood pressure in the body, either it's 80, it's 100, it's 120, or 150, 160, this will still remain constant. Because we know under normal circumstances, whenever there's change in pressure, there should be change in blood flow. But in the kidneys, as long the pressure changes is between 80 to about 170, blood flow remains constant. Okay, so this is a unique thing about autoregulation. Blood flow will still remain constant. So what ensures that the blood flow remains constant? These are called autoregulatory mechanisms. The first one is myogenic, okay, and the other one is the tubuloglomerular feedback mechanisms. So these are the mechanisms that explains why even if there is pressure changes in the kidneys or in the systemic circulation, blood flow still remains constant. So we'll start by looking at the myogenic mechanism. Myo means muscle, genic meaning originating from the muscle. We know there are smooth muscles within the arterioles. So what does the myogenic hypothesis state? It states that increased arterial pressure stretches the blood vessels, which causes reflex contraction of smooth muscles in those blood vessels, resulting in increased resistance to blood flow. That's all. Let me repeat. The myogenic hypothesis states that increased arterial pressure will stretch the blood vessels, and that stretch will cause a reflex contraction of the smooth muscles that are in those blood vessels, and consequently increasing resistance to blood flow. So whenever blood flow increases, okay, the arterioles will become stretched, but that stretch will be a stimulus that will cause the muscles within the arterioles to contract, okay, reducing the lumen of the blood vessels. When the lumen diameter is reduced, it means the resistance has increased, and when resistance increases, it means blood flow reduces. Okay. So from this diagram, what can we see? When arterial blood pressure increases, the renal afferent arterioles is stretched. Okay, increased arterial pressure, flow increases. But what happens to the vascular smooth muscles? There is increase of vascular tone, that is constriction. And then when the lumen diameter reduces, the flow will return to normal. So that is a myogenic hypothesis. And then the other mechanism that explains autoregulation is called the tubuloglomerular feedback mechanism. It is called the tubuloglomerular feedback mechanism. So this one is based on what we call the macular densa. Okay, I wrote somewhere here. Tubuloglomerular mechanism that regulates glomerular filtration rate through the renal tubules and macular densa. If you remember the function of the macular densa when we were discussing the juxtaglomerular apparatus, we said the macular densa senses levels of sodium and chlorides. And some books, they talk of calcium. In other words, the macular densas, they secrete they are chemoreceptors or osmoreceptors that senses osmolarity in the renal tubules. And we know the major contributors to osmolarity is sodium, chlorides. Okay. So what happens with this mechanism? Remember, we are describing the autoregulation. So for example, somebody has high blood pressure. It means the rate at which the filtrate will be formed increases. Okay? When that happens, it means that tubular fluid flow rate will also increase. That is the rate at which the formation of the fluid increases. So in that fluid, there will be increased concentration of sodium and chloride, which will be delivered to the macula densa. And we say that the macula densa, they are located on the distal end, or the distal convoluted tubule. So the macula densa will sense that, and it will release, we said, chemical substances such as adenosine. And then adenosine has receptors on the afferent arterioles, and it causes the afferent arterioles to constrict. When they constrict, it means resistance has increased. And when resistance has increased, it means blood flow reduces. So here, renal blood flow reduces. So in this way, we have controlled, the kidney has controlled the amount of blood flowing to it. Okay, so this is called the tubuloglomerular feedback mechanism. So what we are seeing here in the tubuloglomerular feedback mechanism, when renal arterial pressure increases, okay, both the renal blood flow, both the glomerular filtration rate will increase. And the increase in the glomerular filtration rate will result in increase of delivery of solutes and water to the macula densa, which is part of the early distal tubules. Okay, and it is part of the juxtaglomerular apparatus. So this is going to respond by secreting a vasoactive substances, mainly adenosine, others are prostaglandins, kinins. Okay, so these, they have local vasoconstriction on the afferent arterioles. Then they'll reduce the renal blood flow, they'll reduce the glomerular feedback, glomerular filtration rate back to normal. Okay, so that is about the macula densa. So there's this question. Now that we've looked at the two mechanisms involved in regulation of blood flow to the kidneys, what happens when the concentration of sodium increases in the filtrate? What happens when the concentration of sodium in the filtrate increases? So when GFR increases, concentration of sodium chloride increases in the filtrate, the macula densa will release adenosine from ATP. Most likely, adenosine is secreted from the basal membrane of the cells. It acts via the adenosine A1 receptors on the macula densa cells to increase their release of calcium. Okay, not on the. It acts on the via adenosine A1 receptors on the afferent arterioles, not macula densa, just a mistake, on the afferent arterial cells to increase their release of calcium to the vascular smooth muscles in the afferent arterioles. This causes afferent vasoconstriction and a resultant decrease in glomerular filtration rate. Now, the opposite question is this. Okay, this is just a diagram showing the mechanism. Okay. Okay, actually it's like this. So there is increased operation of the sodium 2 chloride potassium, increased operation of the ATP, this pump, resulting into release of adenosine, which binds to the receptors, the JG cells, okay, which are modified smooth muscles on the afferent arterioles. So it will cause vasoconstriction. Now, the opposite question can be asked. What happens when the concentration of sodium decreases in the filtrate? Sodium would decrease in the filtrate when there is low blood pressure. Okay. It will decrease when there is low blood pressure. But we want a situation whereby the low blood pressure shouldn't be low. It should be raised back to normal. So there is a need for macular denser to secrete the prostaglandins, the bradykinins, the renin. We say these are vasoconstrictors or vasodilators, I mean. PGE2 and bradykinin will cause dilation of afferent arterioles. Renin will induce the formation of angiotensin 2, which is a vasoconstrictor. So the dilation of afferent arterioles and constriction of efferent arterioles lead to increase in glomerular blood flow and glomerular filtration rate. Okay, in summary, we've been looking at renal blood flow to the kidneys. We said that the kidneys receives 1,200 mils per minute of blood. Okay, this blood flowing to the kidneys is very important. Okay, because the kidneys, they are purifying the blood. They are removing toxins out of the system. If these toxins are not removed, they may become detrimental to the body. They may lead to death. Okay. So there are times when the blood pressure is low. However, this should not affect renal blood flow. Okay. So, even if there is changes of blood pressure, renal blood flow to the kidneys will not be affected as long the pressure is between 80 to about 170 millimeters of mercury. So to ensure that renal blood flow is constant, there are two mechanisms that regulate this. There is a myogenic hypothesis, and there is the tubuloglomerular feedback mechanism. Thank you very much. We'll end here.